Okay, we'll go ahead and get started. Thanks everyone for joining. My name is Jordan. I am a licensed clinical social worker in Oklahoma and also the Haruv USA coordinator. For those of you who may be joining us for the first time, Haruv USA is a training institute focused on training topics related to the identification, treatment and prevention of child maltreatment. We are housed out of the University of Oklahoma's School of Social Work in Tulsa and part of the much larger Haruv Institute in Jerusalem. I'm very excited today to introduce Dr. Gloria Castro, who will be leading our training today on perinatal child-parent psychotherapy. I am going to mute myself in just a minute, but throughout the training, you're welcome to enter in through the chat, comments, questions. We're hoping to have this as interactive as possible. But with that, Dr. Castro, the floor is yours.
Okay, thank you very much, Jordan. And thank you very much for everybody connecting this morning or at night, probably for some of you. I really appreciate being with you this morning. I am right now in California, and I just want to introduce myself a little bit so you have an idea in terms of who I am and the type of work that I am doing. And I just want to share with you that I am an immigrant from Mexico City that came to this country like 35 years ago with a baby who was 10-month-old and also a son who was at the time 5 years old. And we were coming to San Francisco actually because my husband was going to be doing a postdoctoral fellowship at UCSF. And we were supposed to come here only for 2 years. And as you can tell, the 2 years became 35 years. And now the Bay Area is my home. And when I came to the United States, one of the things that I was encouraged to do was to go back to get an American degree. I had my PhD from Mexico City. And then at the time, many years ago, I was working at the Children's Hospital that was part of the National Medical Center in Mexico City. And when my kids were a little bit older, then I decided to go back to get an American degree. And I got my doctoral degree here in the Bay Area. And I had the privilege to do most of my training at the Department of Psychiatry at UCSF, specifically at the infant-parent program. I worked with them for many years doing infant-parent psychotherapy as well as early childhood mental health consultation. And then Alicia Lieberman, Dr. Lieberman invited me to come to her program to be able to support her around developing the perinatal mental health model. CTRP at the time, they were working a lot with pregnant women, and they were doing the adaptation of CTP to the perinatal period. On the other hand, I was working at San Francisco General Hospital through the infant parent program. I was working in different units. For example, I was in the high-risk OB/GYN clinic, and then I was able to support the pregnant women throughout pregnancy and labor and delivery at San Francisco General Hospital, and then their babies were receiving their pediatric care at the Children's Health Center at UCSF, and I was also part of that. So my idea a couple of years ago, like 25 years ago, was how we were going to be able to provide to our clients a continuity of care during the perinatal period. And so my whole work has been providing that, you know, how we were able at some point to integrate perinatal mental health in the primary care in different units. And I work also providing a lot of therapeutic support at the neonatal intensive care unit at San Francisco General Hospital. So that is the type of work that I have been doing. And today, one of the things that I am going to be doing is giving you an introduction of what is perinatal child-parent psychotherapy. What we are doing, Dr. Lieberman and I, what we have been doing is that we are trying to develop a way to disseminate a training, a learning collaborative of perinatal CPP. But today we are going to focus only on an introduction. This is not the training that we provide. This is an introduction. The training is more detail oriented. We explore in a lot of details, several aspects, and the training lasts 18 months. And then for a year and a half, we provide conference calls in which people are going to usually present their clinical cases, and we explore those cases in depth. But this morning, let's focus on what is perinatal child-parent psychotherapy. And I am going to share with you my screen. And one of the things that I would like to do is that I would like to invite you to, when you have a thought or a comment that you would like to make or a question, please let me know. Do not wait until the end of the presentation, because I want all of us to have this conversation together, okay? Instead of being only a monologue. So please feel free to not to interrupt me, but to stop me, and I will be able to address your thoughts, wishes, or questions. Okay, so let me share my my email. I want to, first of all, I want to acknowledge that the perinatal child-parent psychotherapy is something that it was developed by specifically the co-authors of the book that is called Making Room for Baby. That was written by Dr. Alicia Lieberman, Dr. Manuela Diaz, and also Griselda Oliver Bucio, and I also contributed in terms of writing the book. And I hope that when you have some time, if you can also review a little bit of the things that I am going to be talking today, but we have them with a lot of detail in the book. Okay, so, no, I'm sorry. I am sorry. I am not giving you the right okay. Now I am in the right PowerPoint. So let's start. I usually, when I am presenting about the perinatal period, one of the things that, that I like to do is to remember one of the most important pediatricians and psychoanalysts that we have had in the field of infant mental health, that is Donald Winnicott. And I really like this quote, that I would like to share with you, because I think that perinatal CPP is exactly this, is to acknowledge when, for example, a baby becomes a baby, And he used to say that the story of a human being does not start at 5 years old or at 2 or at 6 months, but it starts at birth and even before birth. And this is something that we take into consideration when we are working with pregnant women, because you will see that one of the most important things is to try to understand when this baby that is about to be born or that the baby has been born when and how the baby was conceived from a psychological point of view. So now let's talk a little bit. Why is it important to start providing clinical interventions during the perinatal period? And I think Dr. Lieberman and I, we have been talking a lot about that the reason why we want to capture this developmental stage is because we are going to try to avoid any psychopathology that can become if we do not address some of the most important issues that are happening to these pregnant women during the perinatal period. And we are going to have personal stresses as well as sociological realities. And one of the things that we are going to see is that one of the stresses that women can perceive are physiological, because there are going to be significant changes from a physiological point of view in their bodies during the pregnancy, as well as during labor and delivery and the postnatal period. There are going to be also another source of stress is the psychological transformations that occur during the perinatal period. You know, there are going to be some changes that we can identify in terms of the relationship that this woman is having with significant others. And so for us, it's very important during the foundational phase to be able to identify the risk as well as the protective factors that this particular client is bringing into the therapeutic relationship. Then there are going to be other sources that of a lot of stress that we really need to take a time to think about this. And these are the sociological realities that are happening at this particular moment here in the United States. It's amazing that the United States is one of the most richest countries of the world, and it's very sad that the maternal mortality has doubled in the last 30 years. And we see a lot of increase in access to appropriate prenatal care for the underserved minority groups. And another thing that we have been able to identify is that the mortality rate is very high in Black mothers, and also there are a lot of issues when their babies are born. And this is not only with Black mothers. We have identified similar patterns with Latin American people who are living in the United States. What are some of the issues or the challenges that we see in when we are working with pregnant women? First of all, I would like, although here we put it here at the end, you know, I want to start with the medical challenges, because a lot of the women that we are working with, they have significant medical challenges. Like, for example, they have high blood pressures, the high risk for preeclampsia. And the reason why we really need to take into consideration the preeclampsia during the whole treatment is because the likelihood for these women during labor and delivery to start having seizures is very high. So the medical challenges include also, for example, gestational diabetes. And also we need to consider that sometimes during the whole pregnancy, the mothers are monitored if they have prenatal care, and they are going to bring us some of their most important concerns when the doctors have been telling them that there is something that is very concerning in terms of how their babies are developing, and the possibility that they are going to have a preemie instead of having the baby at the gestational age of 40 weeks, okay? So the medical challenges is something that we always assess and keep in mind when we are working with these women. The other thing is that we need to identify if there is violence within the family, within the household, and we need to take into consideration this and to be able to talk about this and to help them, the mother, to understand how that interpersonal violence is going to have a huge impact on the baby that right now is growing and developing inside her. Okay, we also work with women who are dealing with a lot of substance use and that have very little social support. And also another factor that we consider during the perinatal period is how the mother or the father are developing their maternal or paternal identity during the different stages of pregnancy. Okay, and I have been talking a lot previously about the sociological realities here in the United States, and we also really need to pay attention to this, okay? And the reason is because if we can capture these pregnant women and we can provide the coordination of prenatal care as well as providing them with perinatal mental health services, what is going to happen is that the well-being of the mother is, we will be able to see that, but at the same time, we are securing a healthy development in their babies, and that is important. The reason why we try to start our services very early, if it's possible during the first couple of weeks during the second trimester, is because when we provide this type of modality of treatment, we are trying to see if we can avoid the transmission of trauma from one generation to another one. We know already, because of all the research that has been done, that women who have significant child maltreatment and interpersonal violence, they are very likely to develop postpartum depression. And if the woman develops the postpartum depression, what happens is that she's not going to be available emotionally or physically available to her baby during one of the most important periods of development of the baby after the baby is born, okay? These mothers, if we do not provide therapeutic support, these mothers are very likely to engage in child abuse, and their babies are going to be likely to have a poor perinatal outcomes. When we are talking about the poor perinatal outcomes, we are talking about a very low birth weight, very low scores in the APGAR, as well as that the babies are sometimes they are born before the 40 weeks of gestation. And then we have a big issue having a baby who is born, for example, at 24 weeks, okay? Because this baby and the mother are going to require more intense attention. Another thing that why we really need to keep track of the mental health of the mother is because all this prenatal maternal stress is going to be linked, as I was mentioning to you, with a fetal development, okay? The physiology of the placenta is going to be impacted, and as well as the structure of the brain of the baby. Another aspect that we have been, identifying is that there are going to be some changes in the respiratory sinus arrhythmia. And what does this mean? This is considered the RSA, a marker of self-regulation. And you are going to be hearing this morning how a lot of the interventions that we are going to be providing are targeting, how we can support the mother to be able to self-regulate, because when she has her baby, she will need to be doing a lot of co-physiological regulation. And it's important that to think about why after the baby is born, during the first couple of weeks, the co-physiological regulation is going to be the foundation for emotional and behavioral regulation of the baby. And when I am talking about co-physiological regulation, I am talking about the great opportunity that clinicians that we have when we are doing perinatal CPP, that when the baby joins physically the treatment, we are going to be able to have a direct experience of how the mother is feeding the baby. And the mother is going to talk a lot about the sleep patterns of her baby. And those are moments in which we will be able to intervene in order to support the mother with her self-regulation and with a co-physiological regulation. At the end of this presentation, I am going to present a clinical case in which you will be able to see how we work with this, okay? And of course, if we attend all of these sources of stress, what is going to happen is that we are avoiding a long-term risk for psychiatric conditions in the baby. Well, perinatal CPP has different lenses, okay? And one of the important lenses is that this is that we use is that we take into consideration the different developmental stages, not only of the mother or the father, but the developmental stages of the baby, prenatally and postnatally, okay? This is a model who is based on relationships. And remember, relationships have meaning. And so the therapeutic relationship that we establish with the client is going to be a very important vehicle to be able to address other things. Remember, this is a relational-based model and always with the trauma lens, okay? Trying to understand when we are working with a mom, trying to understand the behavior of the mom and how we can explain a particular behavior as a trauma response, okay? And all of this within the cultural context. So perinatal CPP, we have been, Dr. Lieberman and I, we have been talking a lot with the dissemination team of Child-Parent Psychotherapy because, you know, there is, at the beginning, we were talking about that perinatal CPP was an adaptation of CPP in the perinatal period. Right now, Dr. Lieberman and I, we have been thinking a little bit about if this perinatal CPP is an extension of CPP during the perinatal period. But one of the things that I have had a conversation with Dr. Lieberman is that we should take into consideration that when we are working with these pregnant women and later on with their babies, we are trying to integrate infant mental health and how we are going to make observations between the interactions between the mother and the newborn. And I think that from that perspective, we really need to acknowledge that we are incorporating a lot of infant parent psychotherapy, even in the way we are making behavioral and emotional observations between mother and baby. Okay, so PCPP is, we are using a lot of psychodynamic perspective, but also we are also keeping in our mind all the work that has been done in terms of attachment, the work in trauma, of course, social learning, and many other multicultural theories. What is important is that we also use cognitive behavioral therapy. Personally, and I need to be very transparent about this, I use some CBT interventions, but I do not conceptualize my cases from a CBT perspective, okay? It's more from a psychodynamic perspective. And then the therapeutic focus that we have is that we are going to address psychogenic beliefs. There are going to be distorted perceptions that the parents are going to share with us. We are going to address not only the negative attributions that they are giving to the baby, but as well as the positive attributions, okay? And we are going to be able to support the families in terms of how the mother and the father, if the father is going to be involved, how they are developing their maternal and paternal identity in different developmental stages, okay? Because at the beginning, one of the biggest issues is that the mother is not, the pregnant woman is beginning to become aware that she's not only the daughter of her parents or the sister of her siblings or the partner of her partner, but right now she's entering in something that it's called the family constellation, in which the mother is developing her identity as a mother or as a father. And even if they have had other older children, they are developing this maternal identity for this particular baby. And a lot of the work that we do is around that, okay? And also we like to think about how the traumatic experiences that the mother has had in her past are going to shape the way she relates, you know, to different people that are around her, including the image that the mother has about her baby. I'm sure that probably most of you are aware, you know a lot about ghosts in the nursery and angels in the nursery. And the only thing that I want to for us to address right now is that the ghosts, they are not going to invade only the womb of the mother, but also the nursery. We are going to see a lot of negativity to the pregnancy, specifically for those parents who became pregnant and they did not plan for this pregnancy, okay? And there is going to evoke a lot of regret, shame, and guilt about continuing with the pregnancy. And we need to address all of that. And as I was talking to you before, is that the negative parental attributions to the unborn baby are going to be named, and we need to work through them in different developmental stages of the perinatal period, because probably we were able to do, the mother and the partner were able to do a beautiful work about understanding where these parental attributions are coming from, but during pregnancy. But once the baby is born, they again have these attributions and they take a different shape, okay? I am going to share with you how the way we conceptualize this type of work is that we have, and I will explain with more detail later, we have like 3 triangles, you know, and how the mother, all the traumatic experiences that she has had in her life are going to determine the way she's thinking and feeling and acting in her life, and specifically about the pregnancy. But if you add the other triangle about pregnancy, what happens is that if the mother is dealing with very difficult medical issues or psychological issues during pregnancy, that is going to have an impact on the way she's going to perceive and to relate to her baby. So it's important to capture these moms, the early, the better, okay? Another thing that is very good to consider is how all of this is happening in a context, you know, and how we are going to address that. Important to know if the basic needs of this pregnant woman are met, if they have concrete emotional support, that their emotional support network is good for this mom, and how she perceives the medical response, the medical care, how she's perceiving the medical care. And also if she has been able to access to reproductive health services and to lethal impact of systemic racism and unconscious bias, okay? Because that is a lot of what we see when the mother has not been able to trust the medical system because she has experienced that there is a lot of discrimination. So here, what are the therapeutic modalities of perinatal CPP? We have first of all, the emotional regulation. And I was talking to you about how we are going to support the mom to be able to self-regulate. So in order to do that, we need to keep track of her feelings and her body sensations. Then we are going to use interventions like, for example, the diaphragmatic breathing, and also when the baby is born or even before the baby is born, how the mother is keeping physical, like, for example, touching the baby. And suppose that the baby is a preemie baby, the mom will not be able to caress her baby like this, okay? Because the baby has been born very early. So the baby's body and was not ready for this particular life. So sometimes when I was working at the NICU, one of the things that we were working with these parents is that they can have a physical contact with the baby, even if the baby is less than 25 or 24 weeks, but they cannot do this, okay? They need to touch the baby like this. So those are the kind of things that we are going to provide them. If the baby is doing fine, then some of the moms and fathers, they want to provide infant massage. We are going also, one of the therapeutic modalities is that we provide non-didactic developmental guidance. So we do not teach these parents to become a better parent. We are going to give them the developmental perspective, but in a way that is not about teaching them what they need to do. It's for them to be able to understand the meaning of, for example, one of the behaviors or one of the emotional states of their babies. And in the clinical case that I am going to present, you will be able to see how I was providing that to the family. We also connect the mothers to different places in the hospital so they can get information about reproductive health and family planning. We do not wait until the baby is born because it's very common, at least here in the Bay Area, that once the baby delivers the baby, when the mother delivers the baby, the nurses come and start bombarding them about what is what you would like to use now to, for family planning, when the mother psychologically is not there. So this conversation needs to happen before the mother goes to labor and delivery, okay? And of course, we are going to provide concrete assistance in terms of meeting the basic needs of the family. But something that I would like to highlight is that we are not going to be resolving or solving all the problems that the families have. We are going to connect the families with different programs that will be able to provide that concrete assistance. For example, when the mother and the baby are going to be discharged from the hospital, I usually connect them with a family resource center here in San Francisco, and they are going to provide them with a car seat if the family has not been able to get a car seat. Okay, and of course there are going to be some crisis intervention. And when I am doing the long-term training in perinatal CPP, we talk a lot about that, okay? And to define what is a crisis. But I don't want to take a lot of time with that right now. Now, let's go a little bit about what are the goals of perinatal CPP. And is, as we were talking, is to be able to provide them with an experience in which they can heal the difficult or traumatic experiences they have had. So they have to become aware of them. They need to work through them in order to not to pass them to the next generation, okay? With perinatal CPP, one of the things that we have been learning is that the parents are telling us that they are having right now, after the treatment, a better self-understanding, okay? So this piece is important. The capacity that the parents have to reflect on the experiences that they are having. And we, as we can see here, we try to enhance the maternal or paternal reflective functioning, and also their capacity, their loving capacity to provide safe and nurturing care for their baby. I would like only to mention a little bit about the pillars of therapeutic attitude. That are a couple of them. One of them is notice feelings in the moment. And one of the things is that usually what we try to do is to help the mother to become aware to those memories that sometimes they are not here, the memories, but little by little, the mother is able to retrieve the memory. But what we need to support them is with trying to get the affect to that memory, because they can remember, oh, I remember that my father used to do this, this, and that, but without any affect. So what we want is for her to retrieve the affect, to integrate the affect in order to be able to start the healing process, okay? And here, another aspect that is very important that we constantly talk about is speaking the unspeakable. And when we do this, is, for example, some clinicians are afraid that if they address the trauma during pregnancy, the mother is going to decompensate. But that's why we create a therapeutic container. And we are going to be using the words that the mom is using in terms of describing what has happened to her. Another pillar of the therapeutic attitude is what is happening in the here and now. And sometimes even in the therapeutic relationship between the mother and me, how we are going to help them to find connections between what happened in the past and what happened in the here and now, and for them to make that connection, and that is going to give them a better understanding about why they relate the way they relate. Okay. Another aspect is that what happened when we are dealing with a mom or a dad that are displaying a lot of rage. For me, as a clinician, is to remember what is underneath that rage, and it's always a lot of anger that they are displaying. But this is almost like a self-protection of a lot of fear that they don't know how to manage that fear or another intense feelings. When there is a conflict, Dr. Lieberman always talk about how the conflict can be a bitter disagreement that is coming from a clash between competing values or priorities. And we can see this not only in pregnancy, but in the postpartum period. I want you to remember this, because in my clinical case, I am going to be talking about the conflict between the mom and the baby after the baby was born, okay? So one of the things that we try to do is that we need to be show this compassion. We do not judge our clients. We are trying to be able to be curious and to offer kindness and compassion. And what is beautiful about this is that if I can include all of this in the creation of my therapeutic relationship, it's beautiful to witness later on how the parents are going to do the same thing to their babies. And then encourage hope is important. But here always is that for us clinicians, is not only to let the mothers or the fathers know that there is hope, because also we need to take into consideration the reality. One thing is the fantasy that the parents can have, and how that fantasy is not, sometimes is not matching with the reality. And I was supervising a case a couple of months ago in which the clinician had a lot of hope about this particular case, a woman who had a significant history of substance use and that she had lost her 3 older kids, all of them between the ages of 0 and 5. So the likelihood for this mom who was not receiving substance use treatment, the likelihood for this mom to lose the baby if we do not address certain things, it was very high. So how to work with a clinician to be able to keep the hope, but at the same time, what are the kind of things that the mother and the clinician will need to do in order to maintain that hope, okay? It's not only that I have hope, I will be able to continue with this. So right now, let me stop here for a little while, because I would like to make a pause and to think a little bit how it has been for you to hear this information. Do you have thoughts, questions, something that you would like to comment?
Dr. Castro, while earlier, someone had a question about if there was any information on getting the actual training for PCPP.
Yes. One of the things that I can do, Jordan, is that after this presentation, I can send you the link that the person needs to go to that and register. Usually what we are doing is that we are providing this learning collaborative in a way in which they gather, for example, there is a program and the program wants X amount of people to be trained in perinatal CPP. We are not providing the training individually because it could be it could take a lot of time. And right now at this point, the only people who are providing this training is me and sometimes Dr. Lieberman, okay? When she has the opportunity to be part of the training, she does that. But we are trying to train people within CTRP to be able to disseminate more. But I can send you the link, okay, Jordan? And you can distribute that to everybody.
Okay, thank you. We had another question about how often are fathers involved in this?
A very good question. In my case, for example, here at San Francisco General Hospital, a child trauma research program, in the foundational phase, in the initial meeting with the mom, I always talk to the mom about if she would like to think about including the father of the baby in the treatment, okay? We need to be very careful because if there is a lot of violence between the two of them, that would not be a good idea. But if the mother says, yes, I would like, but you know, Gloria, only for a couple of sessions, that would be wonderful, but I don't want him to be part of this. So we think together about how often the father would come, okay? Something that I want all of us to think about, I have been working with couples, you know, the father and the mother throughout the perinatal period. But one of the things that as clinicians, we really need to remember is that even if the father is not present, in treatment, what is happening with the mother who is in the treatment, something that is going to be very important is that it's going to have an impact on the father. When I go to labor and delivery and see how the delivery was, and I want to see where is the baby in the room. I will talk a little bit more about that later, but usually the fathers are there. And if they are there, I am going to address that, because this baby is not going to live in a bubble. The baby is going to be living, growing, and developing within the family system. So I always address this with the mom. Would you like the father to be part of the treatment? And then together we think about the pros and the cons. But it's important. Mm-hmm. Other questions?
We have another question. What age group for kids is this model best for our research to show effectiveness for?
Can you repeat the question?
What age group of kids is this model best for in effectiveness?
Oh, okay. That is a very important question. What we are doing is that we start working with the pregnant woman, if it's possible, at the beginning of the second trimester, okay? And that doesn't mean that we are not working with that baby who has not been born. We are giving voice throughout the pregnancy to the baby, and that is going to help the mother to bond with that baby. So when we launched the first perinatal CPP training, Dr. Lieberman said, if you want, you can start working with a mom who has delivered the baby, but the baby should not be more than 4 weeks old. What we learned from that decision was that it was very difficult for the clinician to be able to learn the model with a baby who is already there, because they needed to go back to the pregnancy. So it was very difficult. When I am doing the long-term training, I always say, please try to get a pregnant woman. Learn the model, and then what is beautiful about the model is that later on, even if the mother is not pregnant and you are working with a young child, remember that this child, a 2, 3, 4, 5-year-old, at some point, that child was conceived by this mom from a psychological point of view. And it's important to go back and understand that, even if you are not working with the pregnant woman. I hope that this information will help you with the type of work that you are doing.
Okay, we have 2 more questions. The first one, many are mentioning that this is a lot of information to take in. Will the PowerPoint slides be available to view after the presentation?
Yeah, I am going to send it to you, Jordan, and you will be able to distribute this. Okay?
Great.
Of course.
The last question that we have so far is there research that shows any difference in the outcome for the method with whether or not the father was included?
Yeah, because we are just beginning to see the impact that the training is. First of all, there are 2 things. The clinical aspect, what we have been learning using this model in terms of the outcomes for the mom and for the baby, okay? And I can talk to you about that. There is no research already published about this because we are beginning to do this. But I can tell you that the mothers who receive this type of intervention, they are having their babies at 40 weeks. They are able to monitor their symptoms of depression, PTSD, and anxiety, and that's why they are more available to their babies. Their babies grow and develop as expected, and the mom is able to, because she was able to bond with the baby before the baby was born, she's able to have a secure attachment with the baby. Okay, so that's what we are noticing with the cases that we are working with. But that information has not been published yet. Okay, we are doing this.
Okay, we'll take this one last question. How are mothers identified about who would benefit from this?
Okay, usually what we do is a lot of work with our colleagues, the medical providers, midwives, OB, pediatricians, social workers, or other programs in the community. And for example, a mother who is dealing with mental health issues, a mother who is not connecting with the baby during pregnancy, or a mother who is not complying with the suggestions of the medical provider. For example, a mother who is not taking care of her health and how this is impacting already the baby. Those are the type of women that we see. And of course, women with significant history of trauma. Okay. So let's go back, and then we will have another little break to talk more about this, okay, about your questions. Okay, so now we are going to talk a little bit about the different stages of of pregnancy, and when we are using this particular model. So we are going to have, as I was mentioning to you, we are going to see, what I did is that I took the medical model, and I am talking about this from a psychological point of view. So we are going to have the 3 trimesters and the postpartum developmental stage, or the 4th stage of perinatal period. So in the first trimester, the woman is going to react and to try to understand a little bit better, not only the physical sensations and symptoms that she's experiencing during the first trimester, okay? What is important is that let's pay attention what is happening in the first trimester from a physical point of view, and on the other hand, what is happening from a psychological point of view. So from a physical point of view, the mother is beginning to notice that there are some changes in her body, okay? And then the mother begins to try to imagine this baby. What is the meaning of this baby for this mom? In the second trimester is when the baby begins to move, okay, in a significant way. And so the baby, the woman now is beginning to experience that the baby is in a way separated from her. The baby becomes more real, okay? In the second trimester, also we are going to see that a lot of the morning sickness, changes in the mood are going to decrease, and the body begins to change in a significant way. In the third trimester is when we use the ultrasound of the baby in a way to help the mother to see that the baby is real and how she can connect with this baby. And what we do at San Francisco General is that we provide a lot of consultation to the technician, and sometimes the clinician goes with the mother to the ultrasound, and they are asked that please put the screen of the ultrasound not here, not next to the mom, but in front of the mom. And we ask the technician just to describe, this is the face of the baby. Can you see the little fingers, the legs? So the technician is giving a very concrete a description of the baby, and this is going to have two things that are important. One, the mother begins to see that this is a real baby now, and that she needs to be welcoming this baby pretty soon. And on the other hand, the ultrasound is allowing us to be able to humanize the baby. We ask the mom, how are you going to call the baby? And the mother is going to say, let's see, the baby is going to be called Linda. So we begin to talk about Linda, okay? We want to humanize that baby, not to become, because from a psychodynamic point of view, what happened is that the baby can become the object. And that is fine for us as clinicians to conceptualize that. But what is important is for us to be able to give voice to the baby and to see, you know, Maria, I was able to see during the ultrasound how you were moving. And it's because you are blah, 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 okay? So that's what the way we use the ultrasound. There are some psychological changes, and I don't want to go in detail about this because you will have the PowerPoint and you will be able to understand what is the meaning of this. But one of the books that I really encourage you to look at is the Family Constellation that was written by Daniel Stern. Because he talks a lot about the psychological changes during the perinatal period. And he talks about how, and I mentioned to you before, how the mother is going to redefine who she is and who other people are, okay? She will have the opportunity to reprocess of all conflicts. And usually what happens is that what happens is that the mother is going to be to bring into her awareness the conflicts that she has had with her own mother, and we will be able to work through that. And then the Stern also talks about the maternal affective dynamics, is how we in the container that we develop for therapeutic interventions, how we will be able to contain the ambivalence that is part of the normative development of the perinatal period, and how we are going to support the mother to deal with the distress and the feelings of anger that she's going to display. So I think that the most important thing is to think about how, because we are addressing the perinatal period, all of these things are part of the normative development. But if we would be looking at this in a different context in which the mother is not pregnant, then is when these issues become a little bit like we can think about pathology. But here, in this developmental stage of perinatal period, is completely a normative development of all of this. It's not pathology. And also Stern talks about four themes that we are going to see constantly in our clinical work. When the mother or the father are going to be able to think about, to reflect about, am I going to maintain the life and growth of my baby? Am I going to be emotionally engaged with my baby in a way that is going to be genuine? And because this is going to help my baby to develop her own sense of identity, okay? And then we are going to be talking and addressing the social network support, you know, and to help the mother to look at this, because they are going to ask questions like, can I create and maintain the necessary support system to fulfill the other functions? And then, you know, another big clinical issue is, am I able to transform my self-identity to permit and facilitate all of these functions, okay? It's not only that I am the daughter of my parent or the partner the partner or the wife of my husband, but also I am developing my identity as a mother. Here, I include some of the issues that have to do in terms of what are some of the aspects that the mothers are going to bring into therapy and the fathers are going to bring into therapy, okay? And I will leave you this, and you will have the opportunity to read this in the PowerPoint. I don't want to spend a lot of time doing this, and because we have other things that are going to be very important. Here, you know, I developed this, and here you will find the 3 trimesters and what type of interventions we develop in the different trimesters. And I want to share with you how, for example, during the first trimester, the mother has this idea of the imaginary baby. So a lot of what we are going to be doing is to explore if this particular pregnancy was something that they planned and they wished, and how other people in the family responded to that. In the second trimester, we are going to deal with a symbolic baby that the mother has in her mind. That means, what is the meaning of this baby for this mom? And we see this in the second trimester. And for example, is when we are going to be exploring the maternal attributions or the paternal attributions. And during the third trimester, we are going to prepare the mom to be able to welcome the real baby, not the baby that she imagined or the baby that she's thinking that this particular baby is kicking me all the time because my baby is doing this intentionally and he's going to be exactly like my father. That is an attribution that does not have to do anything with the real baby. So during the third trimester, hopefully we were able to work through all of these in this trimester, and we will help the mother to be able to welcome the real baby. And the phases of perinatal CPP are the foundational phase, the feedback session, the core phase, and the closing phase, that is a way in which we invite the parents to recapitulate and also to, be able to reflect on their experience during this period. So the way my colleagues and I, we organize the foundational phase is that they usually take like between 3 and 5 sessions, and we are going to be discussing in those sessions who is going to be part of the treatment. We are going to frame the dyadic or triadic work to them, because it's important to be able to, for us to understand how the mother understood the referral, because sometimes they come to us thinking that this is going to be individual therapy or is going to be couples therapy. And we do not do that. We work with a triad or with a dyad, okay? And we are going to be able to identify if there are safety issues, if the mother is in danger, if there is a lot of violence, okay? And during pregnancy, what we are going to focus is on the ghosts in the nursery and the angels in the nursery, okay? And the case for formulation and feedback is how we are going to, once I gather all the information, how I am going to explain to the mom the meaning of having that information in order to understand the way she is thinking, feeling, and behaving, okay? And together we are going to co-create a treatment plan of care and to see what are the priorities that we need to take into consideration, and of course, who is going to participate. Okay, and this is exactly what I was mentioning before. Something that we do is that we are going to assess the perinatal mood and anxiety disorders throughout the session, throughout the pregnancy. And we are going to keep track of their level of depression, anxiety, PTSD, and we need to make interventions about this, you know? And we have a particular protocol of doing perinatal CPP and that we use in child trauma. But sometimes when I am preparing to do a learning collaborative with universities or with other mental health programs, I have a period in which I talk to the director of the program or the supervisors to be able to understand how is the clinic or the program in which they are going to provide PCPP. And sometimes they need to adapt the protocol based on the needs that they have. So this is something that is not very rigid. So here is how I am going to explain to the mom how what she shared with me, all the experiences or the traumatic experiences that she has had in her life. And I am not going to be talking, you know, when you were little and your father hit your mom and your mom hit back your father. No, I am going to take themes that are there that we can talk about, for example, how, for example, the mother was abandoned or the neglect that she endured or the violence that she endured. And we are going to talk about this, the experience, and also to identify the thoughts, feelings, and how she behaved in relationship to this. And how this experience is going to determine also the way the mother is experiencing this pregnancy. And specifically, what are the difficulties or the traumatic experiences that she is having related to her pregnancy, and then how this experience is going to have an impact on the way she perceives the baby. So these are three triangles that are, you know, together, but it's important for us to be able to see how that is going to be displayed in different moments during the treatment. In the formulation triangle, we are going to be talking, as I was mentioning about the external reality, the conditions in which the mom is living, but also the internal reality that the mother has to explain. You live this, and this is the way you responded, and internally, this is the way you are perceiving that. And the treatment goals, we are going to, the most important thing is to create safety, to enhance a protective attachment, and to promote well-being, not only for the parents, but also for the baby. Okay. In the feedback session, what we try to do is to contextualize and normalize the traumatic response, okay? And they are going to learn little by little to make a difference between reliving the trauma versus remembering the trauma, okay? There are two things that are completely different. If they relive the trauma and they haven't been able to integrate that difficult experience with the affect, what they are going to do is that they are going to reenact that situation with a baby. And this is exactly what we are going to be focusing in trying to avoid that, okay? We are going to promote self-understanding and emotional regulation. And also we are going to be able to address all these perceptions that the mother can have about the baby that are completely distorted, okay? But we can set these perceptions within the context of the traumatic experience that she had, and how the exploration of the mother's traumatic responses during treatment. It's important to name. Do you remember when I was saying speak the unspeakable? It's important to name the traumatic responses that the mother is having, not only in the transference with me, but with other people in the community, for example, with the doctors, okay? In the core phase, what we are going to do is to deepening the foundational work, and we are going to be able to be going from between the present, what is happening right now, the immediate past, let's say the bad experience that the mother had with the OB, and the childhood experience that they have, how lonely they were feeling, the fear that they were having, and their rage, okay? So part of the work is to seeking the emotional meaning of the specific memories and fears. And in the core phase, we are going to be addressing all of this, you know, that I am going to leave you with the PowerPoint and you can go one by one. But I think that what is going to be very important is for us to, with the clinical case, to be able to see how all of this looks like, okay? And speaking the unspeakable, you know, is important because when someone has been impacted by trauma, there is a lot of shame and self-blame. And these are completely normal, universal responses to the traumatic experience, you know, like, for example, a belief that I am a bad person, I made it happen, and I will cause harm. And this piece is important in the postnatal period, how the mother sometimes is afraid of harming the baby. Identifying and dispelling these pathogenic beliefs is a core strategy in every treatment, regardless of the theoretical orientation. But in perinatal CPP, this is very, very important, okay? And then what happened when the mother and the father welcomes the baby and they begin to make room for the real baby, okay? How they are going to perceive the baby, we are going to address that. Also, what are the coping skills that they have been able to develop and how they are going to look or to ask for external support during the postnatal period. And then how they are going to be able to tolerate the ambivalence, okay? For example, when a mother says, Gloria, I am feeling so exhausted, I haven't been able to sleep, and at some point last night, I wanted to run away and to leave my baby at home. I really need to get out. But on the other hand, I know that she needs me because she's very little. Do you see the ambivalence and how we work throughout that with them? And then in the termination phase, how we are going to say goodbye is we are going to invite them to reflect about how was for them, what they learned about themselves, and sometimes they are going to make some statements like, for example, I cannot believe there was a time when I did not love my baby, when I was not taking care of myself, and by not taking care of myself during the first couple of months during pregnancy, I was not taking care of my baby. Okay, another thing that is important in the closing phase is to anticipate the future. When we say, you know, when a mother, you will see in the clinical case that the mother was able to say, I had a big issue saying goodbye and separating from my own father. So right now I am aware of that. And when my daughter begins to walk or to crawl and she will be moving in order to explore the environment, I know that I will be available for her when she needs me. But also I am going to respect and that she needs to separate from me to explore the environment. You know, and I need to work on that. But she's anticipating that that is going to happen. So right now, I would like to spend the rest of the time, you know, introducing you to this particular family. The name is Sonia, is the mom, Oscar the father, and Mia is the baby. And I am going to introduce you to this beautiful family that I worked with them until the baby was 1 year old. And Sonia was referred by her OBGYN provider when Sonia was at 26 weeks gestational. And the referral source report that Sonia was not attending her prenatal appointments as it was expected. She was having difficulties coping with her gestational diabetes, her hypertension, and was not showing any interest in her baby. It's like she never talked about the pregnancy when she was going to the prenatal care. And Sonia, also, when I met with her, she was having severe difficulties falling asleep. This is very important. This is a symptom that you will be able to understand why that was happening. And unable to enjoy activities with Oscar, with her partner. She was having poor appetite, crying a lot, and Sonia has declined the home visits of a public health nurse during pregnancy. So she did not want that type of support. And Sonia is living with her husband, Oscar, who is the father of the baby, and Sonia's parents live in Antigua, Guatemala. So in the foundational phase, the purpose was getting to know Sonia. So in the first call, I introduced myself and explained that her OBGYN doctor asked me to contact her. She knew I was going to call her. I asked her if she knew why she was referred to our program. And she mentioned that the doctor was concerned about her missing prenatal appointments. She said she has been feeling sad with lack of energy, and sometimes she does not feel like herself, especially since she got pregnant. Then I respond. She said, I do not have enough energy to wake up early and go to the hospital. I do not know how other women enjoy being pregnant. Something is wrong with me. It does not feel good. I am so embarrassed. I cannot believe I am thinking these kind of thoughts. I feel very bad. The way I responded was, it's hard to take care of yourself when you feel this bad. I know it feels like you are the only one who has ever felt this way. It's hard to envision yourself laughing or enjoying yourself again. But let me tell you, this is going to happen. So in this interaction with her, I am acknowledging, validating what she's saying, but also I am normalizing that, okay? And at the end, I am installing hope because I am telling her, you will be able to feel different later on. With this interaction, I was trying to become an authentic attachment figure for Sonia through engaged empathy and becoming a stable source of safety and support. I was holding and containing the intense symptoms in early sessions and foster a sense of control and comfort through the therapeutic relationship. For example, I was asking her when it could be better for you to come and see me. Do you want a morning appointment or an afternoon appointment? By giving her back the control is something that she's regaining the control that was taken away during different traumatic experiences she has had in her life. And this allowed me to rely on the strength of the therapeutic alliance to be able to redirect and encourage the development of her new sense of self as her pregnancy advances and leads her to her new role. So one of my goals was to support her through the development of her identity as a mother, and also not only that, but also to learn a little bit about, or to start thinking about what is going to be her new role. And several things happened. I tried to hold her with compassion and to provide her with hope. I started to create a safe space for unconditional acceptance of the worst part of herself, as she perceives them to be. She's saying, I cannot believe I am having these thoughts. Well, I am holding that for her in the therapeutic experience, in the therapeutic space. Sonia asked how often we would meet, and that was an opportunity to frame the work. And I responded, we could be able to schedule an appointment for next week. I would like to ask you if you could meet with me for 2 hours. We will have the opportunity to get to know each other and to talk about how it has been for you since you found out you were pregnant. We will talk about if you would like to invite your husband to these meetings, or if you would like to think about it. I am looking forward to our next meeting, in which we will be talking more about your experiences and to think together about how you could feel better to be ready to welcome your baby. So again, I am talking about how important it's going to be for this woman to have hope, okay? And before ending the phone call, I asked her if she would like me to call her one day before the appointment to remind her about the appointment. And she said yes. The clinical rationale about letting her know that I could remind her about the appointment is because of the level of anxiety and depression that she was experiencing. Okay, she needed a little bit of extra support, and that's exactly what I did, okay? In the first session, I welcomed her and anticipated how we would be spending the time together, the 2 hours. I let her know that I would be asking many questions, and the purpose of doing this was to get to know her better. In this way, we would be able to think together about how we will be working, okay? But I anticipated her that I was going to ask her a lot of questions because we use a lot of questionnaires to assess different domains, okay? So Sonia was engaged and she was able to provide all the information that I was asking from her. I noticed that she was insightful and she provided important information in various domains. She talks about her childhood history, the current stressors that she was having, the perinatal history that she has, and the social support network that she had. So Sonia was talking in that session, I want you to notice, she was talking about difficult experiences during childhood. Her father, she was from Guatemala, and her father came to California when she was a 2-year-old. She was in a family in which there was a lot of poverty. They did not have enough food available. And she said to me, I was feeling always with a void. I was always hungry. This piece of information is very important to keep in our mind to understand what happened when the baby was born, okay? The immigration history, she told me that one of the things is that when, that she had these benevolent memories. I don't know, I made a mistake here, sorry. It's not about, this woman is not from Mexico, it's from Guatemala. I made a mistake. And she talked about the immigration history, how she was able to come to the United States. And for a couple of months, she was living with her maternal grandparents, and she had beautiful memories about feeling love, care about them. And those memories play an important role in her life, okay? Another thing that she mentioned that I was not told about when I got a referral is that she had an intrauterine fetal demise. She lost her baby when she was 38 weeks gestational. That means that she lost this baby a year before this pregnancy, 2 weeks before she was about to deliver the baby. one of the some of the protective factors is that she has a strong social network support because her family is already in California. And also she described Oscar as a loving and caring husband, although the loss of her first baby had an impact on the way on their relationship, okay? Sonia was very insightful and open to interventions. She was engaged from the beginning and attended sessions weekly. And Sonia and Oscar talk about the possibility of attending some sessions because at the time, Oscar was having 2 jobs. One of the risk factors, of course, is the loss of the previous baby. And that, what happened is that one day she stopped feeding the baby and she rushed to the hospital. The doctors saw her, they did a sonogram, and the heart of the baby was okay. And they said, if you do not start with contractions by tomorrow morning, please come to the hospital because we will need to induce the labor, okay? And also, she was able to say, what is happening to me with this particular pregnancy is that this pregnancy is a reminder of my previous loss. And I want you to see how by not bonding with this baby, you know, while she was pregnant, was a way in which she was protecting herself because she didn't know if this baby was going to make it or not. But all of this is unconscious, okay? And how these, as I was mentioning to you, how these factors were interfering with making room for Mia. And not only physically, but also psychologically, okay? Another important thing is that I was able to get a clear picture about how she did not trust the medical providers, and that's why she was not coming to the hospital. After the loss of her child, she was referred to a support group that was not a good experience for Sonia and Oscar. She was telling me they were teaching us, please listen to her words. They were teaching us what could happen to us in the future. We needed something else. We needed someone to say that it was fine to feel so upset and sad because my baby died, okay? And what the system was trying to do is to provide them support. And she told me about what the doctor told her in her after she delivered the first baby, that she went to her appointment with them, and the doctor said, we couldn't understand why this happened, but your body is ready to be pregnant again. I had to have a conversation with the doctor because I was trying to understand why the doctor said that. We had a beautiful conversation, and I talked to the doctor, and this was a way in which I was introducing the perinatal lens in the medical setting, you know, by saying, yeah, you are right. Probably physically her body is ready for another pregnancy, but what happened is that she's not ready for another pregnancy, okay? And it's very important to talk to providers about not communicating to the mom after a perinatal loss that you can get pregnant soon, because they need to do a particular work in order for them to connect with this particular baby. They need to let go the baby that passed away, okay? And that is something that we do in perinatal CPP. And Sonia mentioned that for the first time, she was able to talk about losing Martin. It was a baby boy before he was born. She acknowledged how terrified she was feeling during this pregnancy. And Sonia mentioned the meaning of not being able to say goodbye, neither to her father nor to Martin. And let me stop here, because what happened with her father was that when she was a 2-year-old, the father would go to Guatemala to see the family, and everybody was very happy, very excited. But then she remembers that at some point, she woke up and the father was not anymore in her house, and she couldn't understand why the father was not there, and nobody was explaining to her that her father was coming back to California. Okay, and this is something that created a lot of internal conflict for this mom. Okay, so and this was going to be displayed during pregnancy and also during the postnatal period. So during the giving feedback to the mother, one of the things that I said is, it makes sense that the experiences you have had in your life as a child, not having the opportunity to understand why your father left without saying goodbye, and as an adult, the way you lost Martin, have evoked intense feelings of abandonment, sadness, and a sense of void in your body and in your soul. Because she told me that when she delivered Martin, she was able to experience in her body a void. And remember, this is a woman who has shared that she always was very hungry during her childhood, feeling a void. So these experiences have had an impact on the way you are experiencing this pregnancy and the difficulties you are having in thinking about your baby. The fact that you are attending the appointments will help us to work together to take care of yourself, to enjoy this pregnancy, and also to be ready to welcome Mia. In the core phase, I want to share with you one of the things that we had to do. First of all, the focus was on mourning the loss of Martin. Also, to address the painful experiences or traumatic experiences she had as a child, and also to make sense of what has happened to her, Then, in terms of mourning the loss of Martin, Sonia and Oscar were able to work through profound grief related to the loss of their baby, and also here is very important. A lot of the work that I did with them was to be able to work through that the baby that they thought they were going to have was not the baby that they had and died. So that imaginary baby was not the baby that they thought they were going to have, and they needed to work through that. And she also was not the mother that she thought she was going to be for Martin. She was a mother for Martin who did not have the opportunity to relate to Martin, okay? So both of them mourned the loss of the baby they imagined they were going to have, and mourned the real baby that they had who died before birth, okay? During the core phase, they were able to say goodbye to Martin. The experience of losing Martin, the impact of the loss of Martin on Sonia's sense of self. Her idea was, my body failed. I am not a woman who can deliver a healthy baby. I was feeling my baby growing, and suddenly I was not feeling my baby anymore. The next pregnancy became a constant reminder of that loss. When Martin was born, I remember feeling a void in my body, but also a void in my soul. Sonia and Oscar wanted to know the gender of the baby. The image of the baby in the screen when they were having the ultrasound helped Sonia and Oscar to have a real image of the baby girl they were going to have done. And they called her Mia, okay? So Mia became from being an object to become a subject for the parents. Mia was humanized. And during the sessions, I used the name of the baby, Mia, constantly. The anxiety that she was experiencing due to the perinatal loss was preventing her from enjoying and connecting with Mia, okay? And so both of them needed to construct a narrative of the loss that they had. They made a connection between early childhood memories of abandonment by her father and the lack of protection, and how this experience was having a huge impact on the development of her sense of self as a mother. She was not feeling that she was going to be able to protect her baby. After Mia was born, her traumatic childhood experiences re-emerged again in the form of unfounded fears for the baby's safety and overprotective behaviors to keep her safe. One of the things that I want you to see is that when I went to visit them at the hospital, I invited them to be able to construct a birth narrative, you know. But in order to do that, first, before they went to the hospital, we developed a birth plan. I am not going through this because you will have the slide and you will have an idea how we construct that. But and in order to do this, we invite the father and they take the birth plan to the hospital, so the hospital knows exactly how they are planning to experience labor and delivery. So we were preparing Sonia for labor and delivery, and I provided her with a lot of support, a lot of anticipation, and to see what are the type of things that she will be able to do, not only after the baby's born, but also during labor, okay? Now, when I went to see them at the hospital, I wanted to see, you know, where is the baby? Who is holding the baby? I invited them to be able to construct a birth narrative. And in that birth narrative, I put a lot of attention if the mother and the father included Mia in the narrative, and if they perceived that Mia was an active participant during labor and delivery, or how they perceived Mia in that way, okay? Also, I asked them if they can describe the baby, and I always try to observe if the parents are responding in an appropriate way to the baby's cues in terms of the needs of the baby, okay? And I am going to have the opportunity to be able to see the co-physiological regulation in terms of feeding patterns and sleep patterns, okay? And how the mother is taking care of herself. So it's not only asking them to talk about, you know, their experience of labor and delivery, but for us, the clinician, to be able to identify the affect of those memories that they are articulating to me, okay? One of the things that the mother said was that labor and delivery was the most powerful experience of my life. The opportunity to reconnect with my body, becoming a mother, has been like entering into a different realm. And this is exactly what Stern talks about. The mother enters into this motherhood constellation, okay? My relationship with my mother is also changing because she had the opportunity to ask her mother, why you never explained to me that my father was not disappearing, that my father was coming back to the United States, because I was feeling so bad when I was unable to see him. And the mother told her, I never explained to you, I never anticipated to you that your dad was going back to the US because I wanted to protect you. You were very little, okay? But at least they had that conversation. The mother told me also, giving birth was an important act of separation, but I did it in a completely different way. She was prepared for that. And also she said, it was amazing to remember how my body took the control Your body does things without you actually making the commands. It was a very different experience of trusting my body. Remember, this woman, at some point in the previous pregnancy, she went back to her home after she was told, the baby is doing fine, go back to your home and try to rest and come back tomorrow. And what happened is that during that night, her first baby died, okay? So she was saying, now I was able to trust my body. I was getting to know my body during this situation. During the postpartum period, we are going to see some primitive anxieties that are going to come. I would like to focus on this because this piece is very important, the physiological regulation. What happened with the mother was that she was waking up constantly and going to see the baby and make sure that the baby had not died, that the baby was breathing. And every time that she was doing that, what happened is that Mia would wake up, and then the whole cycle of sleeping was completely interrupted by this. And Sonia started to make connections between her fear of losing Mia while she was sleeping with the intense feelings of losing her father when she was a 3-year-old. She did not see him again during her childhood. When she came to California as a teenager, after a couple of weeks, her father died in a car accident. So I want you to see how sleeping was also always with someone is disappearing, and at the end, someone is dying, okay? So we were able to work through that, and she was able to bring the affect, to integrate the memory with the affect, and immediately she stopped waking up constantly to make sure that Mia was alive. Another thing that I noticed during the feeding episode is that Mia was fed for a couple of minutes and stopped and began to cry. And Sonia became very anxious and redirected Mia to the other breast without any time to be able for Mia to reorganize herself. And Mia moved her head away from the second breast and cried in a way that it was very difficult for me to witness. And she could not, the mother was unable to soothe Mia, and now both of them were in distress. So I was able to provide developmental guidance regarding feeding in a newborn. So I was saying, oh my God, Mia, you are doing a beautiful work trying to latch to the nipple, and you are drinking the milk in a very avid way. And it's amazing because what you are doing as a newborn is that you are learning to be able to latch, to suck, to swallow, and to breathe at the same time. That is a lot of work, but you are doing that in a wonderful way. And one of the things that we can say right now is probably, Mia, I am wondering if you need a little bit of time between one breast and the other one. And then I said to the mom, tell me, what do you think about that? And then she said, oh, Gloria, I never thought about the hard work that Mia was doing. And I said, yes. And it seems that because she's learning to do all of these things at the same time, she ends up falling asleep. So probably she needs a little bit of time before you offer her the other, the other breaths. During the final stage, both parents were able to reflect on how they experienced the pregnancy, the way they mourned the loss of Martin, the way they were becoming parents, and welcoming Mia and enjoying her, and also saying goodbye in a different way to the clinician. and the clinician provided anticipatory developmental guidance. What does that mean? What does this mean? I am going to stop right now. That means that I am going to talk a little bit with the mom and with the father. So tell me a little bit, what is your plan about when Mia begins to crawl or to walk? How that is going to be with you? Because remember that she was having a very traumatic experience when her father separated from her and came back to the United States. And immediately the mother told me, it's going to be difficult to be separated from her. But now I understand that when she walks, is important for her because she's going to explore the environment. And I need to be supportive around that. And I thought, this is a beautiful way in which we are going to end the treatment and also for me to hear that she was talking about the future. It's going to be difficult for me, but I will do whatever I need to do in order to support my baby to explore the world. That was beautiful. So right now we have like 10 minutes left, and I would like to spend this time to invite you to talk, and you can just raise your hand and you can talk to me a little bit about how was for you all this information. That of course is a lot of information, but in general, what I want to know, what is the flavor of perinatal CPP that you are taking with you today?
Before we get to that, there was a couple questions in the chat.
Okay.
So the first one was, how long does PCPP typically last? I know there might be case-by-case situations, but what's the typically?
No, Jordan, that is an important question. At the beginning, we thought that it could be a pregnancy. We would cover pregnancy and the first 6 months of the baby. What we are learning is that 6 months is not enough. And the reason is because if the mother is still having some depression or anxiety symptoms, that is going to have a huge impact on the gross motor development and also on language, specifically expressive language. So we wanted 6 more months extra to make sure that the baby was developing and growing as expected. So we cover pregnancy and until the baby is a year old to make sure that the baby is developing and growing as expected.
And one last question. You kind of covered this in the case study, but is there any other general ideas on how pregnancy loss or natal loss is handled within this model?
One of the things that I have been doing, when I provide the learning collaborative, the long-term training, and then I meet with the participants of that training twice a month for an hour, and they talk about their clinical cases. One of the things that I have been doing in parallel is that I have been developing specific modules that I am using when I am doing this. If you bring to my attention in one of the conference calls that for like this particular woman, that she lost this baby, the first baby, I am going to provide one of these modules, an extra training about how we work with women who have had a perinatal loss, okay? I have developed that, but that is in addition to this. Right now, I want to be able to incorporate that, but the themes are so big that it's impossible to address all of that. For example, right now I am working with a program in which one of the clinicians is having twins. So how do we address this? Having pregnant women with twins, how we are going to work with this twin and this twin even during pregnancy. We talk about that. Remember that this is only an introduction, very general, okay? But we have that. What other questions, Jordan?
Just one more before we invite people to give their feedback, but are there any other modules that you've developed for this method?
It's what I was explaining to you. I have developed different modules for different kind of things. Is perinatal loss, what is the meaning of having a baby in the NICU. Another module is to go in depth about the foundational phase, but from a psychodynamic point of view. I developed another one in which we talk about defenses in newborns and defenses in the mother, but within the context of physiological co-regulation. Yes, I have several modules that I have developed. Oh, that is a very important question about postpartum psychosis and recovery from this. In terms of postpartum psychosis, it's very important two things. If you are working with a mom who has been dealing with bipolar disorder or schizophrenia, but the mother has not been receiving appropriate psychiatry care, the likelihood for this mom to develop postpartum psychosis is very high. Actually, I have to tell you, my first case of a pregnant woman that I have at the infant parent program was a woman who developed postpartum psychosis. And that particular situation requires of hospitalization of the mom, even if she is in the postpartum period, because sometimes the intrusive thoughts that they have about hurting the baby are very, very high. So they need a hospitalization, and you need to work with a psychiatrist in order to do this, okay? So I don't know if you have other comments, thoughts, or if you can share with me a little bit of the flavor that you are taking with you regarding perinatal, the perinatal period.
I can just verbally share that in my home state, I think that there's such a need for an increase in these services. So I'm so appreciative to you, Gloria, and the work that you and Dr. Lieberman have done, and your willingness to train and support people to continue to do this work and expand it throughout our nation. So I would just say thank you.
Oh, you're welcome, Annie. I hope that we will be able to disseminate this in to other places. Right now, I am working with 4 hospitals in New York, providing the lens of perinatal mental health, and I am working with another clinician in Germany, who he works with babies who were discharged from the hospital with the nasogastric tube, and he's very interested in learning about how he can use some of these ideas in the model that he developed, that he does home visit. So yes. Oh, I'm so happy that this was helpful. And right now, I think that one of the previous comments is that someone said, I am about to be rostered in CPP. And because one of the things that the dissemination team at CTRP has been working is that in order to take this particular training, the long-term perinatal CPP training, you need to be rostered in CPP. Although there are a lot of people who have been in contact with me that they are not going to work in CPP, and that they are working with pregnant women. So Dr. Lieberman and I, we are talking a little bit about this.